Imagine the scenario. You've got this magnificent horse, looks strong, vital, everything seems fine. Then suddenly, almost inexplicably, it just starts to falter. Lethargy kicks in, maybe you notice its gums look kind of pale, maybe even yellowish, and breathing becomes a real effort. What if the reason behind all this wasn't some bug or injury, but actually the horse's own immune system attacking itself? It sounds pretty shocking,
Mm.
right? But it's the reality of a condition called equine immune-mediated anemia, or IMHA for short. So today on the deep dive, we're really going deep into IMHA. We've gathered a whole stack of info, clinical guides, research papers, overviews, and our mission really is to pull out the most crucial bits for you. Think of it like your shortcut to getting up to speed on this really challenging condition. Whether you're just curious or maybe you want a better grasp of some complex veterinary stuff.
Exactly. And we're not just going to list symptoms and treatments. What's really fascinating, I think, is digging into the why. Why does this happen? Understanding that complex interaction, that sort of delicate dance between the immune system and the red blood cells. We'll touch on some maybe surprising aspects of how the body can essentially misfire. And it highlights why, critical thinking is just so vital when you're dealing with diseases this complex.
Okay, let's get into it then. Let's unpack this. What exactly is equine IMHA at its core?
Well, fundamentally, IMHA is where the horse's immune system makes a mistake. It wrongly identifies its own red blood cells, RBCs, as threats and starts destroying them. It's basically an autoimmune attack, right? And this happens because antibodies, which we call immunoglobulins or sometimes complement proteins, they latch onto the surface of these red blood cells, either onto the cell's own normal markers or sometimes onto foreign things like maybe bits of a virus or a drug that have stuck to the cell surface.
Wow. So the body's own protection system, its defense force, suddenly sees these vital cells as like the enemy. That's a major breakdown. How does that destruction actually happen? What's the mechanism, the how behind it?
No, the how is really key here, the pathophysiology.
Hmm.
There are basically two main ways these red blood cells get destroyed. The most common way is what we call extravascular hemolysis.
Mm-hmm.
So think of it like this. Those red blood cells coated with antibodies or complement, they get flagged as abnormal. Specialized immune cells called macrophages, mostly hanging out in the spleen and liver, recognize these flags. And these macrophages, they're like the cleanup crew. They start engulfing these flagged red blood cells. Sometimes they eat them whole. Sometimes they just take bites out of it.
Take bites at it. So they're literally being sort of nibbled away.
Kind of, yeah. When it's partial phagocytosis, that nibbling it removes bits of the red blood cell membrane. This changes the shape of the cell, making it smaller, denser, and more spherical. We call these spherocytes. The important thing is they lose that typical central pale spot you see in many species red cells, though horse RBCs are less concave to begin with, but this makes them rigid, less flexible, so they struggle to squeeze through tiny blood vessels and get damaged or destroyed more easily later on. And like you said, all this extra work, it often makes the spleen get bigger. That splenomegaly, you can sometimes even feel it. It really shows the scale of this internal battle. Okay, so that's the main way. What's the other mechanism? You said it was less common but more severe? Right, that's intravascular hemolysis. This happens when enough antibody, particularly a type called IgM, binds really effectively to the red blood cells. This binding triggers the whole complement cascade, like a domino effect, all the way to forming something called the membrane attack complex, or MO. You can think of the MOC as basically punching holes directly into the red blood cell membrane. It just ruptures the cell right there inside the blood vessel.
Whoa. So one is like a slow dismantling in specific organs, and the other is like an immediate explosion within the bloodstream itself.
That's a good way to put it. And the consequences of that intravascular explosion are pretty dramatic. You get hemoglobinemia. Free hemoglobin spills out from the ruptured cells into blood plasma, turning it pink or red. And then you often see hemoglobinuria, where that free hemoglobin gets filtered by the kidneys into the urine, making it look reddish or brown. And that free hemoglobin isn't great for the kidneys. It can be toxic, potentially causing kidney damage. But really, underneath both mechanisms, the core issue is this breakdown of immune tolerance. The immune system loses its ability to recognize self. It's like its internal ID system is malfunctioning.
That idea of a malfunctioning internal ID system is quite powerful. So, okay, we understand how it happens. But the why seems critical. Is it usually just a random event, or are there known triggers?
That's a really important distinction. We talk about primary or idiopathic IMHA. That's where we can't find any underlying reason. It just seems to happen. But honestly, that's considered pretty rare in horses. Much more common is secondary IMHA. And here we can often identify a specific trigger, something that kicked off this whole misguided immune attack.
Okay, so secondary is more common. What kind of triggers are we talking about?
There's actually quite a range. Infectious agents are definitely a big category. Things like Clostridium perfringens type A, which can cause nasty gut infections, enteritis. Then there's equine infectious anemia virus, EIA. That's a retrovirus, and it's a serious reportable disease. We also see it linked to protozoal parasites like Babesia equi and Babesia cabali, especially in areas where those are common, causing pyroplasmosis. And Anaplasma phagocytophilum, that's a bacterial agent affecting white blood cells, but it can also trigger IMHA. Really, almost any severe systemic infection could potentially set it off, just due to the massive immune stimulation and inflammation.
So infections are a major player. What else?
Drugs and medications are another well-known group. Penicillins, cephalosporins. These antibiotics can sometimes act as what we call happens. They're too small to trigger the immune system on their own, but they can bind to the surface of red blood cells. And once they're stuck there, the immune system suddenly sees that drug RBC complex as foreign and attacks it. It's like the drug paints a target on the cell. Certain sulfa drugs, like trimethoprim sulfa, are also implicated, and potentially others too. Then you have neoplasia or cancer. Things like lymphoma, leukemia, myeloma. These cancers can mess with immune system regulation. Unfortunately, when IMHA is linked to cancer, the prognosis is often quite poor.
So the cancer itself is confusing the immune system. That adds another layer of difficulty.
It does. And there's a very specific type called neonatal isoerythrolysis, or NI. This happens just in newborn foals. They drink the mare's first milk, the colostrum, which is packed with antibodies. But if the mare's antibodies happen to target blood type antigens the foal inherited from its sire, those antibodies attack the foal's red blood cells. This is more common in mares who've had multiple foals, or maybe previous blood transfusions, especially if the mare has a different blood type, like lacking the common AA or Ca antigens. It makes her more likely to develop antibodies against those types if exposed. And finally, though it seems quite rare, sometimes even vaccinations have been suspected of triggering temporary immune reactions against red cells.
Wow, that is a huge list. Infections, drugs, cancer, even a foal's first milk. Is there one type of trigger that's maybe harder to track down than others?
Well, sometimes it's those really subtle chronic infections,
Yeah.
or maybe an early stage cancer that isn't causing obvious signs yet. Those can be tricky. And of course, if you investigate everything and still find nothing, you're left suspecting that rare primary idiopathic form.
Right. So thinking about the listener now, if you're an owner, how would you even know? What are the key signs that should make someone think, uh-oh, maybe this is something serious, like IMHA?
Okay, so some signs are general signs of anemia, not enough red blood cells. The most consistent one is probably pale mucous membranes. Check the gums. Inside the eyelids, they might look very pale pink or even white or yellowish. Then there's lethargy, just general weakness. Maybe the horse doesn't want to exercise or tires really easily. You might also notice a faster heart rate tachycardia or faster breathing, tachypnea, as the body tries to compensate for the lack of oxygen. Decreased appetite is common too, and sometimes a fever.
And are there signs more specific to the hemolysis part, the actual cell destruction?
Yes, absolutely. And these are really important clues. Icterus, or jaundice, that's the yellowing of the membranes, the whites of the eyes, sometimes even the skin. That's from the buildup of bilirubin, a breakdown product of hemoglobin. As we mentioned, hemoglobinuria, that red or brownish urine, which indicates red blood cells are being destroyed right inside the blood vessels. You might also notice if blood is drawn that the plasma itself looks reddish. That's the hemoglobinemia. It's also good to remember the signs might reflect the underlying cause, so maybe chronic weight loss if it's cancer, or severe depression if it's a bad infection. Or in foals with NI, it's often sudden severe weakness and jaundice right after birth.
That yellowing or the dark urine sound like pretty clear alarms. Is there any sign that maybe gets missed easily or could be mistaken for something else?
Well, sometimes that initial lethargy or just being a bit off feed, it might get put down to something minor at first. The paleness is key, but you do have to actually lift the lip and look. It can be subtle early on.
Okay, so diagnosis sounds like real detective work. You've got the history, the signs. What happens next? How do vets confirm it?
It really is detective work. You start with that detailed history, medications, travel, everything, and a thorough physical exam. But the lab work is where things get really crucial. A complete blood count, the CBC, and looking closely at a blood smear are vital. Obviously, you'll see the anemia itself, low red cell count, low PCV or packed cell volume, low hemoglobin. We also look for signs the bone marrow is trying to respond, trying to make new red cells. This is called regenerative anemia. Now, horses don't release lots of immature red cells, reticulocytes, into the blood like dogs do. So we look for indirect signs like bigger red cells on average, that's macrocytosis, a higher MCV or more variation in cell size, which is anisocytosis. Sometimes, if it's unclear, a bone marrow biopsy might be needed to confirm regeneration.
And what about the specific things you mentioned earlier, like the clumping?
Right, the red blood cell morphology is key. Agglutination, that spontaneous clumping of red cells, is a really strong indicator. You might even see it as tiny specks in the blood tube. We do a simple test called the saline agglutination test to be sure. You mix a drop of blood with some saline. Normal stacking of cells, called rouleau, will disperse in saline, but true agglutination, where antibodies are gluing the cells together, won't disperse. That persistence is highly suggestive of IMHA. We also look carefully for spherocytes, those smaller, dense cells. They're admittedly harder to spot definitively in horses compared to dogs because normal horse RBCs are already less pale in the center. But finding them consistently definitely adds weight to the diagnosis, and the white blood cell count might be high if there's an underlying infection.
So many little clues on that blood smear. It's not just about the numbers.
It's exactly. Morphology is critical. Then there's the direct antiglobulin test, or D8, often called the Coombs test. This is kind of the gold standard test. It's designed to directly detect those antibodies or complement proteins stuck onto the red blood cell surface. But, and there's a big but, it's not perfect. You can get false negatives. Maybe there aren't enough antibodies to detect. Or maybe the horse already got some steroids which suppressed the reaction before the test was run. And you can also get false positives. Sometimes antibodies stick non-specifically during inflammation or infection, or even after a blood transfusion. So you absolutely have to interpret the Coombs test in light of all the other clinical signs and lab findings. It's one piece of the puzzle, not the whole answer. Finally, other blood tests, the serum biochemistry, can show high bilirubin levels confirming the jaundice, maybe elevated liver enzymes. And a urinalysis confirms if there's hemoglobin or bilirubin in the urine. All this helps paint the picture and points towards needing tests for those underlying causes. Coggins test for EIA, test for pyroplasmosis, maybe ultrasound to look for tumors, that sort of thing.
Okay, that is a complex diagnostic path. So let's say the detective work pays off, the diagnosis is confirmed. What's the plan then? How do you actually treat a horse whose own body is fighting itself?
Right. The treatment really has three main parts. You have to try and find and deal with the underlying cause. You need to suppress that faulty immune response. And you absolutely have to provide supportive care to keep the horse going. So number one, identify and eliminate the trigger, if possible. If a drug seems likely, stop it immediately. If there's an infection, start the right antibiotics or antiprotozoals if it's cancer. Well, that involves discussing options with an oncologist, which is often more complex.
Okay, dealing with the trigger first makes sense. Then how do you stop the immune system's attack?
That's the second prong. Immunosuppression. The main tool here is corticosteroids, like dexamethasone or prednisolone. These are powerful drugs. They work in a few ways. They reduce antibody production. They make those macrophages less eager to eat red blood cells. And they can help stabilize the red cell membranes a bit. Usually you start with a pretty high dose to get the immune system under control. Then, once the horse's red cell count starts to improve and stabilize, you begin very slowly tapering the dose down. This tapering can take weeks, often months. You absolutely cannot stop steroids suddenly or the disease can flare right back up. Many horses need long-term low-dose therapy. It's a real balancing act, suppressing the bad immune response, without completely wiping out the horse's ability to fight off normal infections, like walking a tightrope.
That sounds incredibly challenging, managing those steroids. What if they aren't enough, or the side effects are too severe?
That's a great point. Sometimes steroids alone don't cut it. Or the horse develops issues like laminitis, which is a risk with high-dose, long-term steroids. In those cases, vets might add second-line immunosuppressants, drugs like azathioprine, maybe cyclosporine, or mycophenolate mofetil. Using these might allow for a lower steroid dose, which can help manage side effects while still keeping the IMHA under control.
Okay, so stop the trigger, suppress the immune system. What's the third part? Supportive care.
Exactly. Supportive care is absolutely critical, especially when the anemia is severe. Blood transfusions can be literally life-saving. If a PCV drops really low, say below 12 or 15%, or the horse is showing clear signs of lacking oxygen, a transfusion is needed to buy time. Cross-matching blood types is really important before transfusing to reduce reactions. But even with cross-matching, there's a risk the horse's immune system might start attacking the transfused red cells too. Other supportive measures include intravenous fluids to help with hydration and support kidney function, especially if there's hemoglobinuria. Gastroprotectants like omeprazole are often given to help prevent stomach ulcers, which are a known side effect of steroids. And sometimes, if oxygen levels are critically low, oxygen therapy might be needed.
It sounds like a really intensive process, especially in the beginning. So, if a horse makes it through that initial crisis, what's the long-term picture look like? What's the prognosis, and what does ongoing management involve for the owners?
Yeah, the prognosis, it's always guarded, and it's really variable. Several things influence it. Is it primary or secondary? Like we said, IMHA linked to cancer generally has a poor outlook. How severe was the anemia to begin with? And how well did the horse respond to that initial treatment? Sadly, the mortality rates reported in studies are significant. They can range anywhere from maybe 30% up to 50%, or even a bit higher in some cases. It's a serious condition.
Wow, 30 to 50%. That's incredibly tough. Are there any signs early on that might hint towards a better outcome, or is it always just a waiting game?
A quick positive response to the initial steroid treatment, seeing that PCV stabilize and start to climb fairly quickly, that's generally seen as a more positive sign. But yeah, even then, you have to remain vigilant, because even if they recover from the acute phase, long-term immunosuppression is often needed, and there's always a risk the IMHA could relapse, could come back. And complications can happen too, like kidney problems from the hemoglobin breakdown or laminitis, often related to the steroids, or secondary infections because the immune system is suppressed.
So, what does that mean for managing the horse long term?
It means very close monitoring. Frequent rechecks are essential, especially early on, maybe daily checks of the PCV at first, then weekly, then monthly, as things hopefully improve. That slow, careful tapering of the immunosuppressive drugs is critical to avoid relapse. This can take months, and like I said, some horses might need a low dose of medication potentially for life. Client education is huge. Owners need to know exactly what signs of relapse to watch for paleness coming back, lethargy returning. For NI, owners need to know about preventative strategies like using stored colostrum from a safe mare for foals identified as high risk. And of course, if a specific trigger was identified, like a certain drug, avoiding re-exposure to that trigger is absolutely crucial.
It really underscores the complexity, doesn't it? Equine IMHA. It's a powerful reminder of how intricate the immune system is, this amazing defense force that usually protects us, but also how incredibly delicate that balance is, ensuring it doesn't turn inward. It makes you think, doesn't it, about all those hidden battles constantly going on inside, not just in horses, but in all of us, and what happens when that internal balance gets thrown off.
It absolutely does, and it also highlights the incredible diagnostic journey, the patience, the dedicated care that's needed to manage these really complex conditions in animals. It really speaks to that bond we have that drives us to understand and to try and help them navigate these challenges, always searching for that equilibrium.